All right. Hey ho, let's go. This is Resistance Radio, where the pathogens don't discriminate, but our policies sure do. We have a full house of stories today: viruses crossing borders, a suppressed government study that finally made it to print, a Legionnaires outbreak in Harlem that most people haven't even heard about, and cheese that has become a public health villain. But today we're not just cataloging outbreaks. Today we're naming the through line, because every single story in today's briefing is at its core a story about policy, about who we invest in, about who we protect, about who we leave behind when the money runs out, and the will fades, or the politics get inconvenient. So let's go. Let's start with the biggest story in global infectious diseases right now, and that is the Bundibugyo Ebola outbreak in the Democratic Republic of the Congo and Uganda. This week, the DRC officially crossed over 1,000 confirmed cases, and as of just a few days ago, the latest tally was at about 1,048 confirmed cases and 267 deaths. Another 20 cases and 2 deaths have been reported across the border in Uganda. To put that in perspective, picture the largest concert hall or arena in your city. Every seat is filled. Now imagine every single person in that building is a confirmed Ebola patient. That hospital staff treating them has to suit up in full PPE just to bring them water. That's roughly the scale of what health workers in the DRC are managing right now. This is the DRC's 17th Ebola outbreak since 1976. 17th. That number is routinely shocking, that it risks becoming background noise, which is exactly the danger. And here's the equity story. This is the Bundibugyo virus, not the Zaire, the strain that we know. There's no licensed vaccine for Bundibugyo. There's no vaccine. The tools that gave us hope just a few years ago in 2018 to 2020 with those DRC Ebola outbreaks, that recombinant VSV vaccine, the monoclonal antibodies, those aren't the right tools for this variant. We are epidemiologically speaking back to surveillance, isolation, and contact tracing, and throw a little prayer in there. What we do have is an experimental antibody drug from MAP Biopharmaceutical. The U.S. has released doses for compassionate use and a clinical trial in the outbreak zone. That's meaningful. This is real, but it's also a reminder that the pipeline for rare pathogen treatments only moves when there's a crisis, not when there's political will. Now, add to this Kenya, which was constructing a 50-bed Ebola quarantine facility near a Kenyan air base funded by the U.S., has halted construction after a court order following community protests. Kenyans said the facility would put their population at risk and strain their health system. Think about that framing for a second. The community isn't wrong to ask questions. Health infrastructure has historically been built near vulnerable populations for political convenience, not with them. The lesson isn't don't build a facility. The lesson is if you want community trust, you have to build community with people, not on top of them. Trust is infrastructure too. Meanwhile, Africa CDC and WHO have launched a 6-month one response continental plan, June through November 2026, requesting roughly $518 million to fund surveillance, lab capacity, clinical care, infection prevention, community engagement, and research across affected African communities. Now, $518 million sounds like a lot, but here's how to think about it. The United States alone spends more than that every 2 days on defense. $500 million to build a continental firewall against a virus that could hop a flight to JFK isn't charity, it's self-interest dressed as altruism. And if we're being honest, it's really the bare minimum. Let's pivot to a story that connects Ebola level stakes to every to a very American kind of problem. This week, the JAMA Network Open published a COVID-19 vaccine efficacy study that the CDC's own director had blocked from publication earlier this spring. This study was originally slated for the MMWR, the CDC's signature scientific publication. Acting CDC Director Jay Bhattacharya delayed it, citing a methodological concerns. The results between September and December of 2025, healthy adults who got the updated COVID-19 vaccine reduced their risk of emergency department and urgent care visits by 50%, and their risk of COVID-associated hospitalizations by 55% compared to unvaccinated adults. JAMA Network Open published it anyway. And yes, that is a big deal. Here's a good analogy. Imagine your hospital's quality improvement team finds that a new hand washing protocol cuts central line infections by half. And instead of presenting it at ground rounds, administration quietly shelves it because it complicates a budget argument. That would be malpractice at an institutional level. What happened here is the public health equivalent. This matters beyond the wonkiness of peer review. People are making real-time decisions about whether to get vaccinated for themselves or for their children. And those decisions are being made without the best available evidence because the best available evidence was sitting in a bureaucratic drawer. The separate CIDRAP data from June 23rd also tells a similar story. Updated COVID boosters cut emergency and urgent care visits by 26%, hospitalizations by 35%, critical illness by 41% among immunocompetent adults. Think of it as this way. If you have 4 people in a hospital waiting room who are all at risk for severe COVID, one of those hospitalizations with a booster simply didn't happen. One of those ICU stays just disappears, not because we invented a miracle, but because we use the tools we already have and we're honest about it. Let's flip again. Let's move to our third block, the domestic inequity block. Harlem, Haiti, hard cheese, and measles. So let's talk about what's happening in American communities that are already carrying more than their share. First, let's start with Legionnaire's disease in Harlem. A just published report in CIDRAP describes a 2025 Legionnaire's disease outbreak in central Harlem linked to cooling towers, 118 confirmed cases and 7 deaths. One of the cooling towers wasn't even regulated. Legionnaire's doesn't get the attention Ebola does. It's not photogenic, but it does kill people, disproportionately older adults, people with underlying conditions, people in dense urban housing without regulatory oversight of their building systems. Harlem is a community with a documented history of environmental health neglect. This isn't a coincidence, it's a policy outcome. Listeria and soft cheese. The CDC is investigating a multi-state listeria outbreak tied to requesón, a soft fresh cheese popular in Latin American cultures, and soft ricotta, a Clover Hill dairy now recalling all of its cheese products. Foodborne illnesses sound mundane until you know who it hits hardest: pregnant people, older adults, the immunocompromised. Listeria doesn't care about your diet preferences, it cares about your immune status. And the communities most likely to eat fresh, unaged cheeses are often immigrant communities buying it from smaller suppliers, are also the communities with the least access to recall notifications in their language, the least flexibility to miss work for illness, and the least margin for error when a pregnancy does go wrong. Let's shift again to measles and the erosion of elimination. Florida has reported 154 measles cases across 15 counties this year, the highest in 25 years. Across the Americas, there have been over 20,500 confirmed measles cases and 25 deaths in the first 5 months of 2026 alone. Measles was declared eliminated in the US in 2000. Eliminated. That wasn't a gift from nature. It was a result of decades of sustained, boring, unglamorous public health infrastructure, school vaccination requirements, WIC programs, outreach to underserved communities, robust immunization registries. We are watching that inherence be spent in real time. Under vaccination doesn't happen randomly. It tracks with distrust, access gaps, language barriers, and years of communities being let down by the very systems now asking them to trust a needle. Measles elimination is a policy achievement. Losing it is a policy failure. Neither is accidental. All right, let's shift to the global alarm board. Everything else we need to name out loud. All right. While Ebola dominates the headlines, there are secondary tickers running in the background that deserves a few seconds of your attention. Yellow fever, 51 confirmed cases and 24 deaths so far this year globally. Chikungunya, 7,484 cases, In Suriname, that's a small county of roughly 60,000 people, meaning roughly 1 in 80 people in Suriname has chikungunya this year. Think about what that means for workforce, for health system, for farming communities. Diphtheria in Haiti, 1,616 suspected cases, 159 confirmed, 5 deaths. Haiti is one of the lowest vaccination rates in the hemisphere after years of political instability, earthquake damage, cholera outbreaks. Now, this diphtheria is a vaccine preventable illness, full stop. Every death there is traceable to systemic failure, not biologic inevitability. And plague in New Mexico has had its first human plague case of 2026. Plague is endemic in the American Southwest. It's not exotic, it's not medieval. It's here. It's disproportionately affecting rural communities with less healthcare access and delayed diagnosis. And dengue, once a travel medicine footnote, is now a year-round risk flagged by the CDC across multiple global regions with cyclical outbreaks every 2 to 5 years. For clinicians, every febrile traveler is now a potential dengue patient, and our clinical radar needs to be recalibrated accordingly. Each of these signals on its own is manageable, all of them simultaneously against a backdrop of funding cuts, weakened public health agencies, and politicized science. That's the part that keeps epidemiologists up at night. So what does all of this have in common? I want to end with the thing that connects all of these stories, because I don't think it gets said plainly enough. Health inequity is not bad luck. It is not a force of nature. It is not an inevitable byproduct of biology. Health inequity is a measurement of policy choices. The communities dying of Ebola in the DRC die because of decades of colonial extraction, political instability, and international neglect, not because the virus chooses them. The people hospitalized with listeria in the US are disproportionately from communities that face the most barriers to food safety information and healthcare access, not because they were careless. The children losing measles protection in Florida come from communities where vaccine hesitancy was cultivated by misinformation ecosystems that were allowed to grow unchecked, not because their parents were irrational. The COVID vaccine study that got suppressed, the COVID vaccine study that got suppressed during a moment when science became a political identity. And the people who will make worse decisions because of that suppression are not the ones with the most access to information. Every outbreak has an epidemiology. Every outbreak has its politics. And until we treat the politics with the same urgency as the pathogens, we will keep standing here every morning, reading these numbers and calling it news. This has been Resistance Radio, where we believe that the antidote to public health failure is not just better science, but better politics, better funding, and the stubborn insistence that everyone deserves to survive an outbreak, not just the people with the best zip code. I'm your host, Mark Allen Derry. Stay informed, stay engaged, and if anyone asks you why you care so much about other people's health, tell them it's because public health is the only kind of health that there is. Thank you.